Please take a moment and pause this presentation in order to review the goals for Chapter 54. So we'll start as usual by defining the concept. And you can see that depending on the organization defining the health disparity, each of those definitions will be a little bit different. However, what all of them have in common is that they all speak about differences. What we want to explore in these concepts is the difference in the quality of care that is received when variables are reduced. The term healthcare disparities is defined as a difference in the quality of care received by minorities and non-minorities who have equal access to care. That is when those groups have similar health insurance and the same access to a doctor, and when there are no differences between these groups in their preferences and needs for treatment. So you can see in here how we define the scope for this concept. And we can see that from the broadest and most simplistic perspective, the scope of health disparities is represented by unavoidable and avoidable disparities. In some cases, this categorization can be easily applied. And I'll give you an example. Disparities in health outcomes by age may be unavoidable because aging as the biological process is not subject to intervention. However, in reality, this type of categorization does not represent the contextual factor that must be considered. Again, for example, disparities in health outcomes due to unsafe living environments could be an avoidable cause of inequality. An avoidable disparity raises ethical questions of needless harm and justice. And indeed, many health disparities are avoidable, and continuous efforts are necessary to identify existing health disparities that are, in fact, preventable. For example, now that we have identified that disparities are avoidable, what are we willing to do about it? What we can do about it? I'm going to give you a quote now. Inequity and inequality. These terms are sometimes confused, but they are not interchangeable. Again, inequity and inequality. Inequity refers to unfair, avoidable differences arising from poor governance, corruption, or cultural exclusion, while inequality simply refers to the uneven distribution of health or health resources as a result of genetic or other factors or the lack of resources. And I end the quote here. So, a good illustration of such differences in definition is found here. Those covered by national health insurance schemes in various countries, as NHS in UK, Medicare in Australia, and there are others across the world, have access to health services more or less equally once they are in the system. And this will be regardless of their gender, ethnicity, creed, or religion. However, the ability to benefit from those services is subject to individual autonomous decision-making. It's subject to socio-economic circumstances, to social network. To ensure health quality, extra resources, including affirmative action, are needed to assist those perceived to be disadvantaged to make use of the same service provided by the health scheme. This may include travel assistance rebate or subsidy, income protection or supplementation, and any other means-tested assistance schemes. Before even determining the existence of a health disparity, however, it is required to examine if the identified differences are inequality or inequity. Inequality does not necessarily mean being inequitable. Health inequities indicate differences in health, which are not only unnecessary and avoidable, but in addition to that are considered unfair and unjust. And you can see here on this slide a few of the attributes where disparities can be found. And let's take a look at that. We can have the natural or biological variations, health damaging behaviors that are freely chosen. We may see the transient health advantage of one group over another when one group is first to adopt a health promotion behavior. The health damaging behavior in which the degree of choice of lifestyle is severely restricted, exposure to unhealthy or stressful conditions, inadequate access to essential health services, natural selection involving the tendency for sick people to move down the social scale, income and social status, social support networks, education, employment and work conditions, social environments, physical environments, personal health practices and coping skills, healthy child development, biology and genetic endowment, health services, gender, and culture. So we are going to take a look now to the theoretical links related to the disparities. And there are several different theories associated with health disparities that are used in nursing, and each of those theories has strength as well as limitations in their ability of explaining the health disparities. The social ecological model aims to explain dynamic interrelations among various personal and environmental factors. The social ecological model has been widely used in nursing research and practice related to health disparities because it provides an understanding of interrelationship of individuals and systems, and it can provide a perspective to identify health disparities at each system level and directions for intervention at each system level. For example, the social ecological model allows nurses to identify cultural barriers in access to healthcare at the level of the macro system and to develop an intervention in order to tackle this cultural barrier and to reduce any subsequent health disparities. Another model is the structural constructivist one, and it's based on an assumption of dual nature of human existence. This model adopts a constructivist perspective that the reality of life is based on mental representation constructed by a combination of socially shared understandings within a society. Simultaneously, the model adopts a structural perspective that people are constrained by the external structures in which they are embedded. For example, the social relations created by the shared and distributed expectations of others. Health disparities literature featuring this model exerts that the concept of race or ethnicity is socially or culturally constructed with the underlying logic that when we can control the ways in which race or ethnic groups differ, the racial or ethnic disparities will disappear. In this model's perspective, there is a strong support of the idea of social and cultural construction of race or ethnicity that frequently results in health disparities observed in healthcare systems. And it gives directions for nursing research and practice in understanding those health disparities in both clinical and community settings. The cultural competence movement grew out of early efforts to bridge the divide between the largely biomedical, white, middle-class American culture perspective of clinicians and perspectives of patients, mainly immigrants, whose experience and language put them at a substantial cultural distance from the American healthcare. The cultural competence expanded in the late 80s through the 90s in three ways. First was the fact that the population of interest expanded from primarily immigrants to essentially all racial or ethnic minority groups. Second, the conceptual boundary expanded beyond culture per se to such issue as prejudice, stereotyping, and the social determinants of health. Third, the scope expanded beyond the interpersonal domain between patients and healthcare providers to health systems and communities. Cultural competence in healthcare entails 1, understanding the importance of sociocultural influences on patients' health beliefs and behaviors. 2, considering how these factors will interact at multiple levels of the healthcare delivery systems, as organizational or structural or clinical. And the third one will be devising the interventions that take these issues into account to ensure that the delivery of high-quality healthcare to diverse patient population. Despite the existence of several different models of cultural competence, several key elements are shared at interpersonal and organizational levels. Interpersonal interactions focus on the ability of a provider to bridge cultural differences to build an effective relationship with a patient. Healthcare organizations focus on meeting the needs of diverse group of patients. Nevertheless, the cultural competence model has been criticized due to its exclusive emphasis on healthcare providers to improve health disparities. So this table, it gives you some guidance for personal interactions and organizational actions to demonstrate cultural competence. Remember that good nursing care does not come from treating all patients the same. It is best to treat each patient as the unique individual that they are. This means one must gain knowledge of each patient's beliefs and values, meaning of illness, preferences, and needs. Please take a moment to stop this presentation and review the key elements of cultural competence on this slide. Let's see what is the context to nursing and healthcare. So, health disparities seen in the context of nursing and healthcare largely represent healthcare disparities. They are seen in various nursing settings and or situations and are roughly categorized as unavoidable and acceptable, unavoidable and unacceptable or unjust, avoidable and acceptable, and avoidable and unacceptable. So as we will discuss each of this, try to think of an example of each type. So the health disparities that are unavoidable and acceptable should not be a concern for nurses. For example, in an emergency room, nurses could observe health disparities in emergency visits by age. In general, older people make more emergency visits compared with younger people. In this situation, age becomes a determinant of the disparity, and aging is unavoidable and acceptable. Health disparities that are unavoidable and unacceptable can also happen in healthcare settings and should be a concern for the nurse. For example, high prevalence of diabetes among Hispanic populations might be partially due to genetic factors, so that such a disparity in the prevalence of diabetes could be unavoidable. However, health disparity due to differences in access to healthcare for diabetes treatment is unacceptable, which raises a concern for nurses. Most health disparities that are avoidable are not viewed as acceptable, and these situations are rare in healthcare. However, there are unique and unusual circumstances in which avoidable health disparities could be viewed as acceptable. And I'll give an example. A health disparity could exist among people involved and those not involved in natural disasters. When a natural disaster occurs, unequal health outcomes among residents in the affected area may be acceptable, even though the disaster and resultant health disparity could be avoidable. Health disparities that are avoidable and unacceptable, unfortunately, occur in the healthcare settings as well, and these are the targets of intervention. For example, a disparity in cancer pain management exists between Asians and whites. The differences attributable to Asian cultural values and attitudes related to cancer pain and pain medication distinguish from the cultural values of whites. This disparity is totally avoidable if Asian cancer patients will be adequately educated and instructed on cancer pain management strategies, including pain medication and complementary and alternative medicine. Also, this disparity is unacceptable because this gives an unnecessary burden of pain to some category of patients that could be easily managed by using existing strategies. Several avoidable and unacceptable disparities are worth further exploration from the perspective of healthcare disparities because they are frequently seen and experienced by nurses. And here are some examples of avoidable and unacceptable disparities frequently seen in healthcare. Now, think a little bit about them and try to find some potential solutions for reducing disparities for each of those causes. Let's see, for example, signage in hospitals must be in languages common use by patients. Also think of interpreter services. So I will just read them for you. Lack of health insurance and high healthcare costs, language barriers, lack of transportation, provider-patient communication, biased clinical decision-making, or patients' mistrust and refusal. Health disparities is a concept closely linked to culture. And nursing scholars have suggested that marginalization due to cultural differences could decrease the opportunities to receive an equitable healthcare, which subsequently will lead to health disparities. They also claim that marginalization due to cultural differences and subsequent disadvantages will include financial, environmental, and linguistic barriers that result in health disparities. Furthermore, cultural differences frequently give rise to issues with communication between healthcare providers and patients, and the miscommunication could cause health disparities. Stereotypes, bias, or prejudice of healthcare providers can be activated or increased by miscommunication with patients, which can then lead to diminished healthcare quality provided to the patients. Unequal receipt of early and adequate prenatal care. Let's take a look at this, and there is a fact that I would like to give it to you. Black mothers are 3 to 4 times as likely to die from pregnancy complications as white mothers. Let's look now to the unequal receipt of recommended immunization. Fact: adult vaccination coverage levels reveal a much larger disparity by race and ethnicity than the disparity seen among young children and teens, with coverage for pneumococcal vaccine in adults 65 years of age and older, diphtheria and tetanus toxoid vaccine, and the zoster vaccine way lower among Blacks and Hispanics compared to white non-Hispanics. Let's look at the unequal pain management. Facts: consistent with the Institute of Medicine's report on healthcare disparities, racial and ethnic disparities in pain perception, assessment, and treatment, all of those were found in all settings. For example, post-operative setup, emergency room setup, and also across all types of pain. That can be acute pain, cancer-related pain, chronic non-malignant pain, and experimental pain. The literature suggests that the source of pain disparities among racial and ethnic minorities are complex, involving the patient, for example, patient healthcare provider communication and attitudes, can involve the healthcare provider, for example, the decision making of the healthcare provider, and can involve the healthcare system, as for example, the access to pain medication. The study found that cancer patients were referred to hospice care around 53 days prior to death, while for non-cancer patients, referral happens around 27 days prior. It is also found that older patients tend to receive less hospice care, with patients aged under 50 years receiving 78 days compared to 59 days for 50 to 75 years old and 39 days, which is half, for patients aged over 75 years of age. Question number 1. Which statement regarding health disparities is true? And the options are, please pay attention. 1. Within countries, health disparities are less evident than health disparities that exist between countries with similar cultural beliefs and social circumstances. 2. Health disparities refer to gaps in the quality of health among population groups that parallel differences in socioeconomic status, racial ethnic background, and educational levels. Or 3, extensive research has been conducted on how the concept of health disparity relates specifically to nursing, advancing the practice of evidence-based nursing. The correct answer is 2. Health disparities refers to the gaps in the quality of health among different population groups that parallel differences in their socioeconomic status, racial or ethnic background, and educational levels. Question number 2. Which of the following is an example of an unavoidable, acceptable health disparity? Hispanic patients with type 2 diabetes have higher morbidity rates than white patients of the same age. 2. An earthquake results in a significant number of injuries and fatalities, and some suffer permanent injury. 3. A patient living in a rural area rarely goes to the clinic for management of chronic bronchitis because she has no means of transportation. And 4. Older patients make more emergency visits than young patients. Remember, we are looking for an example of an unavoidable and acceptable health disparity. The correct answer is 4. Older patients make more emergency visits than young patients. Age is unavoidable. Therefore, this disparity is acceptable.